Very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is no other than Dr. Jardine Fabrice from Rouen, France, and he's going to lecture us on large B cell lymphoma new directions at EHA and ICML meetings. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Roche, Natco, Unipath, Lucien, and Nirvin Life Sciences, and very well managed by Perfect Square. I thank Team Roche, Natco, Unipath, Lucien, and Nirvin, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Siddesh Kalantari from Nashik, our guest speaker for the day, Dr. Jardine Fabrice from France, all our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for sparing a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 15th of November 2025 from 7 p.m. Indian Standard Time and 6:30 a.m. Mountain Time, we have Dr. Manali Kamdar from Colorado, USA, speaking to us on all cards are not the same, the experience from DLBCL and follicular lymphoma. And the following date, it is Sunday, 16th of November 2025 from 11:30 a.m. Indian Standard Time and 7 a.m. Polish time, we have Professor Wojciech Ruzek from Poland, speaking to us on mantle cell lymphoma with the new things on EHA and Lugano. Let me introduce our discussions for the day, and they are well displayed here in alphabetical order. And I will pause for a while for you to have a look on all our discussions over the day, who are very eminent hematologists, hemato-oncologists, as well as medical oncologists all across the country. So these are our discussions for the day. Some more over here. Well, so now it's a time to introduce our guest speaker for the day. We have with us Dr. Jardine Fabrice from Rouen, France. He is the professor of hematology at the Henry Becquerel Cancer Center at Rouen University. He heads a research team dedicated to lymphoma genomics. He is also a principal investigator in several multi-center clinical trials in diffuse large B-cell lymphoma, particularly in elderly patients. He is a member of the LISA Scientific Advisory Board and the French Society of Hematology. Today he's with us and he's going to lecture us on large B-cell lymphoma new directions at EHA and ICML meetings. But before he does that, let me introduce our special guest and chief guest for the day, my friend, Dr. Siddesh Kalantari from Nashik. Let me introduce Dr. Siddesh Kalantari to all of you. He is a consultant hematologist, hemato-oncologist, and stem cell transplant physician at Blood Care Hematology Clinic, Nashik. He is working as hematologist at Blood Care Clinic and Namco Hospital, Nashik. He does MBBS from GMC Mumbai, MD Medicine from GMC Amritsar, and was a university topper, followed by DM in clinical hematology at IHTM Kolkata, and again was a university topper. He has been trained in stem cell transplant as well as bone marrow transplant from the very prestigious ACTRACT part of Tata Memorial Hospital, Mumbai, and Fred Hutchinson Cancer Research Center, Seattle, USA. And he has done around 56 transplants in Nashik in the last 4 years. He has the multiple board achievements, starting from American Society of Hematology Abstract Achievement Award, ASH 20171 Abstract, ASH 20193 Abstracts, Best Paper Award of Hematocon 2017, Best Poster Award Hematocon 2016, First Prize in Hematology Quiz Competition 33rd Annual Conference Mumbai, and he has about 15 national and international publications. It's my privilege to welcome Dr. Siddesh Kalantari to inaugurate a webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Siddesh. Dr. Siddesh, uh, Dr. Siddesh, we are not able to hear you.
A very good morning to everyone, respected seniors and dear colleagues. Thank you, Dr. Khurana, for such a kind introduction. I am truly humbled, MB Agrawal sir, Mumbai Hematology Group, and Dr. Khurana for giving me this opportunity. Yeah, I'll just a second. Can you see me now?
Yes, but your voice has interrupted. Please go ahead. No issues. Your voices are breaking again and again.
Uh, Dr. Siddesh, you can turn off your camera and just continue with the audio. That would be fine.
Dr. Khurana,
Yeah,
can you see now?
yeah, I can hear you. Please go ahead. We can hear you.
Yeah, so I'll just turn off my video and we can go ahead.
Yes, yes, yes. Please go ahead.
Yeah. So I'm truly humbled and honored to be on such a big platform, and I thank Professor MB Agrawal sir, MHG, and Dr. Khurana for giving me such a big opportunity. At the outset, I would like to thank Priya Patil ma'am from JJ Hospital, who way back in 2008 encouraged me to participate in Mumbai Hematology Group quiz competition, and where I happened to meet Professor MB Agrawal sir, and I was inspired by his compassion, passion, and aura at that time, and this is where I decided to take hematology as my career branch. To the young residents and doctors, I would like to say that hematology is growing at a very rapid pace, but please be mindful that your practice is not going to grow at similar pace, and you will have to be patient for at least 4 to 5 years before things start settling down. So in this time period, when there is no work or there is less work, I would request you to spend maximum time with your teammates and try to place in systems wherein things become on autopilot mode once when you are a established hematologist. For that to happen, I think it's very important to not waste your golden days of residency and try to learn everything that is relevant to your practice, right from line flushing, dressing, taking care of central venous catheters, preparation of chemotherapy, and doing stainings, because this is going to help you in long term when you try to settle down in tier 2 or tier 3 cities like Nasik, wherein you don't have trained staff. For this, I would like to thank Professor Maitri Bhattacharya Madam and Professor Naveen Khatri sir for grilling me during my residency days and making sure I learn everything that is important for being a successful hematologist. In the era of NGS, high-end immunotherapy, empathy, clinical judgment, transparency, and human touch should not be forgotten. Our patients are our biggest teachers, and we should always try to introspect on how we would have managed a patient better once that patient is discharged or when we have failed in a few of our patients. Remain true to yourself, your patients, your family members. Success is bound to come. Once again, thank you, MB Agrawal sir, Dr. Khurana, and MHG for giving me this opportunity. Thank you.
Thank you very much, Dr. Siddesh. Wonderful words, well crafted speech, and you really thrown light on what should be done when you start with your practice, because this is very important for the youngsters, because they get frustrated, within 4 to 5 years, no work. And when the work comes, basically, you are out of the academics. Wonderful speech. Thank you
Thank
so much, Dr. Siddesh, for joining as our chief guest for the day. And, sir, screen is yours now. Please go ahead. Dr. Jardin?
Yes,
Yes,
it's
we can.
okay.
Yes, sir.
I can share my slide.
Yes, sir. Please go ahead.
Um, Thank you for the kind invitation. Uh, uh, is it okay for you?
Absolutely perfect, sir. Please go ahead.
Okay, thank you. So I will focus my webinar on the new molecular classification of large B-cell lymphoma and the relationship between this new molecular classification and new treatment strategy. And I will give you some example from the last ASH meeting and the ICML meeting. I try to move the next slide, sorry. Okay. So this is the plan of my presentation. We'll discuss new molecular classification in 2025, their translation in daily practice. I will give you some example of retrospective analysis using this new molecular classification. And we will discuss some new clinical trials based on molecular stratification. And to conclude, we'll discuss clinical trial beyond molecular stratification. Just to remind you that diffuse large B-cell lymphoma is the most frequent lymphoma subtype. In this publication of the LISA group in France, you can see that diffuse large B-cell lymphoma account for 40% of the totality of B-cell lymphoma. The WHO classification in 2016 shows that the term large B-cell lymphoma is encompass a large heterogeneous group of large B-cell lymphoma with highly heterogeneity, clinical heterogeneity, as you can see here in this slide. As you know, there is now two classifications. The fifth WHO classification published 3 years ago in leukemia, and the ICC classification published the same year in blood. In this classification for large B-cell lymphoma, it is indicated that it's quite recommended to classify your patient according to the GCB or the ABC subtype. It's clearly indicated in both classification. But however, regarding the new molecular classification, you can see that there is more cautious regarding the use of this new molecular classification, and now it's not really recommended to use this molecular classification in a daily practice, and there is no clear new entity based on this new molecular classification. Just to remind you, the main milestone of the knowledge of large B-cell lymphoma biology first in the 80s, 90s, it was the time of the discovery of translocation, the discovery of main oncogenes such as BCL2, BCL6, or MYC. And in Rouen, we were lucky to be involved in the discovery of BCL6 that was first described in our city 30 years ago. In the 2000s, it was the time of the use of microRNA and gene expression profile. And as you know, lymphoma was the first cancer were described by gene expression profile by Alizade's team. And at this time, the GCB and ABC concept was born. And 10 years after, we use whole exome sequencing to identify new molecular marker, new genetic variant, recurrent genetic variant that was present in large B-cell lymphoma. But I have to stress that in parallel, we clearly improve the treatment of large B-cell lymphoma, mainly by the use of rituximab in this setting, but you can see that there is no relationship between the knowledge of the large B-cell lymphoma biology and the improvement of treatment. So the question is how to connect the knowledge of the lymphoma biology and the improvement of treatment and prognosis in this setting. And we will discuss this point this morning. Just to remember you that the classification of large B-cell lymphoma is based on two pillars. The first one is activity of ICDA enzyme. As you know, this enzyme is expressed in germinal center and is responsible of somatic mutation, class switch recombination, meaning that this enzyme is mainly responsible of the genetics abnormality you can find in large B-cell lymphoma. Translocation, mutation of putative oncogene or driver gene are mainly related to this activity of this enzyme. The second pillar of the classification is based of the gene expression profile and the connection between the B cell ontogeny, the normal B cell, and the tumor B cells of the lymphoma. And there is a relationship between normal B cell gene expression profile program and this gene expression profile observed in the tumors. So this is the second pillar of the classification of large B-cell lymphoma. As you know, the impact of the GCB-ABC dichotomy is not clearly demonstrated. There is some clinical trials that show that the ABC, of course, is related to a worse prognosis, but not all the clinical trials, not all the series in the world confirm this data. And it's today quite difficult to tailor your treatment according to the GCB-ABC subtype. Just to remember you this paper, it was an important paper, even if now we know that there is many false positive in the results. This paper was the first paper describing recurrent mutation by whole exome sequencing. More than 1,000 whole exome sequencing were performed in this American work, and identify new recurrent mutation and identify also mutations that have good or bad prognosis related to in large B-cell lymphoma, allow to propose a molecular score based on this recurrent mutation. But in fact, it's not used in the daily practice. It's quite difficult to reproduce the data that they found in this publication. And 1 year later, more important publication was done in New England Journal of Medicine by Lou Stott's team, and proposed a new molecular classification. This classification was based on whole exome sequencing of a cohort of more than 500 patients. This cohort was enriched in ABC lymphoma, and they proposed 4 entities to classify large B-cell lymphoma. The first one is MCD, based on the mutation of MYD88 and CD79. The second one was BN2, based on the BCL6 fusion and Notch2 mutation. The third one was Notch N1 or Notch, based on the mutation of Notch1, and AZB to finish based on the mutation of AZH2 and BCL2 translocation. 2 years after, they proposed a new molecular classification with 3 additive groups. The first one is A53, defined by mutation of A53 and more complex genomic abnormality. The second one was based on the subdivision of the AZB subgroup, MYC positive or MYC negative, and MYC positive were clearly related to a worse prognosis in this context and this setting. And the third one was ST2, and I will give you more detail regarding these subgroups. So if you look more in details according to the different subtypes, we can start by the MCD. I think it's the most well-defined molecular subtype in large B-cell lymphoma. It accounts around 15% of large B-cell lymphoma. The clinical presentation is a classic large B-cell lymphoma presentation, but with an increased risk of extranodal disease. We can see also MCD more frequently in elderly patients, and especially in a elderly and IBC patient. Some data shows that this subtype is related to unfavorable prognosis. At the molecular level, as you know, it's dominated by mild AA mutation, but also expression of a specific BCR, mainly related to IgM and the use of VH434 more frequent in this setting. I will give you the correspondence with the other classifications that are proposed now. And in terms of theranostic relevance, this subtype maybe is more sensitive to BCR inhibition, and especially BCR inhibition using BTK target. The second one, well-defined subtype, is a HZB subtype that is a GCB archetype. But as you know, this subtype is heterogeneous, mainly based on the presence of the MYC translocation or not. Clearly, the prognosis is completely different if MYC translocation is observed. Regarding the clinical presentation, it can be a follicular lymphoma transformation presentation or a de novo diffusion B-cell lymphoma. The gene expression profile shows that it's mainly a GCB subtype. In terms of theranostic relevance, there is a discussion regarding the impact of EZH2 inhibitor in this setting. The third subgroup is a BN2 subtype and is defined by BCL6 translocation. Gene expression profile may be related to a kind of marginal zone lymphoma. It's a mix of ABC, GCB, or unclassified at the gene expression profile level. Usually, the prognosis is quite good. And at the molecular level, again, this subtype is characterized by Notch2 mutation and BCL6 translocation. To date, we do not have drugs that can target specifically this subtype. This subtype, A53, is more difficult to define, and it's not defined by all teams in the world, so it's not a consensus subtype. We know that its prevalence is less than 10%. It's a mix of ABC and GCB subtype, and the prognosis is most likely unfavorable. At the genetic level, this subtype is defined by TP53 mutation, but also aneuploidy, a large amount of copy number variation abnormality, and the theranostic meaning of this subtype consequence is not well defined. The Notch1 is also a discussed molecular subtype. The prevalence seems very low, less than 5% in one or two published data. Maybe this subtype will be related to CLL, maybe Richter syndrome or other subtype. In one paper, the Notch1, the N1 subtype was related to unfavorable prognosis, and by definition, this subgroup is characterized by Notch1 mutation, that targets the pest domain. In terms of theranostic relevance, there is one paper showing that ibrutinib can be more efficient in this molecular setting. The last one defined by the LAMF gene panel is the ST2 subtype with a prevalence of 5%, so this is quite rare molecular subtype. It's maybe related to nodular lymphocyte predominant Hodgkin lymphoma, called POPEMA, as you know, or maybe more close to primary mediastinal B-cell lymphoma. Usually in papers, this subtype is related to a favorable prognosis, and the mutational profile is characterized by SGK1 or TET2 recurrent mutation. Again, the theranostic relevance of this molecular subtype is not clearly defined at this moment. Moving to the second one, more important molecular classification proposed by Margaret Chip team, and that we call Harvard classification, and published in the same years, in 2018, by Shapley, Nature Medicine. This molecular classification is based on recurrent mutation, copy number abnormality, and structural variant. So it's only a classification based on genomic alteration and not gene expression profile. And in this new classification, it was proposed to define 5 subtypes based on the analysis of more than 300 exomes. C1 is defined by an ABC gene expression profile, a favorable outcome, and Notch2 recurrent mutation. Group C2 is based on the TP53 inactivation, sometimes deletion of CDKN2A, and is mainly defined by genetic instability. Group C3 is based on the presence of PCL2 translocation, but also other alterations that you can find in follicular lymphoma, for example, such as a CREB-BP mutation. The next expression profile is mainly characterized by GCB profile. Group C4, again GCB, but with a more favorable outcome and based on mutations that target the BCR pathway or the JAK-STAT pathway. And finally, group C5, characterized by ABC gene expression profile, BCL2 gains, and of course mutation of AMID88 gene. This classification was recently confirmed by another bioinformatic approach, again published by Shapley in Blood in the beginning of the year. This classification that we now call DLB class can classify patients again in 5 subtypes, C1 to C5, and it was the same group that I discussed before. It's based on the analysis of more than 600 whole exome data, and you can see that now you can classify all the patients from C1 to C5 as compared to LAMF genes that you classify when you classify only 50% of your patients. Just to highlight that there is some caveats in this classification. First, N1 is not recognized by this DLB class classification. AZB-MYC translocated is not recognized also by this classification. As you know, these 2 subgroups are related to unfavorable prognosis. And I have to stress also that requirement of CNV data implicate a specific variant calling. So the replication of this new classification is, of course, a matter of debate. So to summarize this classification, to date, we have two main molecular classifications: the left gene classification proposed by Lousteau's team, and the DLB case proposed by Margaret Chip and Chapuis. And of course, there is a relationship between this classification. First, I have to stress that there is a third one classification that proposed by our English colleague, based on the expression and the analysis of 300 gene panel. This classification was evaluated in 1,000 patients in England, and they propose now 5 molecular subtypes based only on the mutational status: MYD88, BCL2, SOX1, SGK1, TET2, SGK1, and Notch2 molecular subtype. So it's quite easy to use because you have a limited panel that you can use in the daily practice. And on the right part of my slide, you can see the correspondence between this three molecular classification. Finally, we can now propose a unified 6-class model. As you can see in this slide: MCD MYD88 C5, SZB BCL2 C3, with a subtype with MYC translocation. The Notch1, that is mainly recognized by the English classification and the Lousteau classification. The A53, that is not a consensual subtype, but I think it's important to delineate this subtype. The BN2, Notch2 C1 molecular subtype, and the ST2 or C4 molecular subtype. Another way to show you this classification with this slide, indicating that now we can define the large B-cell lymphoma with this new entity. And if you replace this entity in the B-cell ontogeny, there is again a correspondence between the B-cell development and this molecular subtype. In terms of prognosis impact, it's not clear because there is some differences between publications regarding the clinical impact of this new molecular subtype, and there is no clear confirmation of each molecular subtype. For example, in the right publication, you can see that NCD and N1 were related to unfavorable prognosis. But I have to stress that only 53% of the cohort were classified according to this classification. By contrast, in the Harvard classification, you can see that C5, for example, were not related to unfavorable prognosis. And in the English cohort, you can see also that the MYD88 subtype was not related to unfavorable prognosis. So there is a clear discussion regarding the clinical impact and the prognosis relevance of this new molecular classification. In the LISA group, we try to analyze in a prospective and real-life cohort of diffuse large B-cell lymphoma, and we create a network that is called RT3, and we perform NGS analysis to classify this patient according to the left gene 2.5. You can use this site to classify your patients. Quite easy to use, and we use a dedicated panel of approximately 40 genes that I share with you, and it was quite easy to classify our patient, and we reproduce the data that were published by Schmidt in 2018 in the New England Journal of Medicine, and we were able to classify our cohort of more than 100 patients, and you can see that the distribution of the molecular subtype are very similar that the distribution was initially published in New England. Of course, there is a problem with this classification because this classification proposes only classification of the tumor itself, but no data regarding microenvironment. And you can imagine that microenvironment is a crucial point now to classify our patient, because if you use CAR T cell, if you use bispecific, maybe the microenvironment is a crucial feature of the lymphoma, and a crucial feature to predict the outcome after this kind of new strategy treatment. So there is some classification that propose also to subdivide lymphoma according the gene expression profile of microenvironment. For example, this publication that was proposed by the New York team, and they proposed to subdivide lymphoma according to the GC-like microenvironment, mesenchymal microenvironment, inflammatory environment, or depleted. So four subgroup of based on the expression of bulk RNA and very different microenvironment with clinical impact. However, this classification is not used in daily practice. And we know also there is a relationship between microenvironment and this molecular subtype. For example, in the DLB case, Chapri proposed that there is some molecular alteration that can impact the microenvironment. For example, expression of HLA, expression or mutation of CD70, mutation of CD58, that we know that interact with the T cell environment, for example. And in this classification, the mutational landscape is different according to this five subtype. But the relationship with the microenvironment and the description of the microenvironment is not done in this paper. And finally, to finalize the description of the molecular feature of large B-cell lymphoma, I have to stress that there is a very important feature is the feature defining a molecular high-grade signature. So it was mainly based on the description of high-grade B-cell lymphoma, and two publications in 2019 describing patients with high-grade B-cell lymphoma, double hit or not double hit, but that share a common gene expression profile that is now called dark zone signature, and it was confirmed by additional paper. And this dark zone signature can be observed in patients with double hit, with MYC translocation only, and in a subgroup of patients without any translocation, but with a highly aggressive clinical behavior, including higher IPI, higher stage, LDH elevated, and worse prognosis. And this dark zone signature again is maybe another new feature of the molecular classification of large B-cell lymphoma based on cell of origin. So ABC, GCB, and now I think we can use the term dark zone to define a third cell of origin subtype. So to conclude for this first part of my talk, the ABC-GCB historical dichotomy is not clearly effective to predict outcome. It's remains a very important step for the knowledge of large B-cell lymphoma. Now there is two new models based on the integration of omics data, and as you can see, there is a partial overlap between LymphGene and DLB case. For me, MCD C5, BN2, C1, ZBC3 are well characterized and reproducible across models. For the other subtype, BN1, A53, STG1 are less consensual and less reproducible across classification. The UK group proposed a simplified model based on a limited panel of genes. It is most likely that lymphoma microenvironment is a crucial element for new classification. For me, fish analyses are necessary to identify high-grade B-cell lymphoma, and the relevance of the dark zone signature is most likely very, very important to detect high-risk patients. So the current challenge is to determine the practical utility of this new classification of decision-making and tailoring personalized medicine. So we can move to the second part of my talk based on the relationship between this classification and their use in decision making. And just to remember you that approximately 1/3 of our patients in first line with large B-cell lymphoma cannot be cured because they are primary refractory or because they relapse during the first year after the first line of chemotherapy. But as you know, we are able to cure approximately 60 to 70% of our patients. How to improve the backbone R-CHOP that we universally use in the world. There are many strategies. The first one is to propose large agnostic phase 3 trials with retrospective analysis of biomarkers and predictive factors. You can propose phase 3 trials targeting a subtype of large B-cell lymphoma or prognosis subgroup. You can propose adaptive phase 2 trials based, for example, on the tape analysis or ctDNA. And you can also propose phase 3 trials based on the maintenance strategy. But as you know, and I will not discuss this point today, that this strategy failed to propose new standard treatment because everolimus, for example, enzastorin or rituximab or lenalidomide failed to show any improvement of the overall survival or at least overall survival in this context. So the main strategy to date was based on the dichotomy between GCB and ABC or agnostic phase 3 trial. And I will give you some examples. The first one is a role model trial that was firstly published in 2025 by Davis, showing no clear improvement of the experimental arm based on the addition of bortezomib to R-CHOP. And as you can see in the slide, there is no clear difference between standard arm and experimental arm. But if you look at the subtype, molecular subtype level, you can see that there is an improvement of the overall survival and EFS in the ABC subtype. And if you look at the molecular level again in this table, and the subsequent publication that was proposed again by Davis in the GCO 2 years ago show that in fact ABC and the molecular high-grade subtypes were taken advantage for the experimental arm, showing that maybe bortezomib, addition of bortezomib was benefit for the ABC and molecular high-grade subtype. The second example is a Polarix trial that you know well. I'm sure that compare Polar R-CHP to R-CHOP. And as you know, in terms of prognosis, the effect of the EFS was demonstrated for the experimental arm. and to date without any benefits regarding overall survival. It was indicated in the New England Journal of Medicine in short letter that maybe the ABC subtype will benefit of the combination of polatuzumab and ERCHIP. It was suggested by this the phase 2 trial, but also in the phase 2. And in fact, it was confirmed by subsequent analysis of this trial and presented by Frank Marschauser in the ESH meeting 2023, showing that in fact the ABC subtype will benefit of the addition of polatuzumab. As you can see, for the GCB, it seems that there is no benefit of the addition of this drug, and maybe a trend for the dark zone subtype as I defined previously. According to the DLB case, it was presented in the last ICML meeting that maybe the C5 subtype, based on the mutation of MYD88, benefit of the addition of polatuzumab. In the robust trial, this trial was dedicated to ABC subtypes. You can see that there is no clear benefits of the addition of lenalidomide to the backbone ERCHOP. Regarding the Phoenix trials, you know well this trial. It was a trial based on the selection of patients with a non-GCB subtype. And as you know, for the overall cohort, there will no benefit of the addition of ibrutinib to ERCHOP. But if you look at only at younger patients, less than 60, you will benefit of the addition of ibrutinib. So it was suspected that the addition of ibrutinib was too much toxic, too much side effects in this elderly subgroup of patients, and maybe an explanation of the negative results in the overall cohort. And if you look at the molecular level, the subsequent publication by Wilson in Cancer Cell in 2021 shows that maybe the MCD subgroup benefits of the addition of the ibrutinib molecule. And it was also suggested for the N1 subgroup, but you can see that the number of patients in the N1 was very, very low, and I think it's very difficult to conclude that N1 is clearly a subgroup that can benefit of the addition of ibrutinib. In any case, this results encourage to start a new clinical trial that is called Escalate, that concern only non-GCB diffuse large B-cell lymphoma. It is expected to enroll more than 600 patients, and in this trial, the standard arm is the ERCHOP, of course, and the experimental arm is the ERCHOP plus acalabrutinib. This trial concerns patients less than 75 years old, and only patients with a non-GCB subtype confirmed by gene expression profile will be enrolled in this trial. But you can see that in the main trials, current trials that evaluate ERCHOP plus a new drug, only Escalade and another one that is named Believe are based on the molecular classification. And Believe it's also BTK inhibitors, covalent BTK inhibitors that is mainly concern only patient with the MCD subtype. For the other one, in this table, you can see that there is no design according to the molecular classification. And Why? Because I have to stress that the prevalence of molecular subtype is very variable according to clinical trials, and especially the MCD. For example, you can see that the subtype of MCD was concerned less than 10% of the patients enrolled in the POLARIX trial. In the Phoenix trial, even if this trial was dedicated to ABC subtypes, you can see that only MCD were observed only in 15% of the cohort. And in the guidance trials conducted by our Chinese colleague, you can see that the MCD were concerned only 20% of the patients. So the prevalence of MCD, for example, is quite variable according to clinical trial, according to the molecular classification. So the conclusions you can draw are variable according to this prevalence. In this slide, just to show you that the main clinical trials that are currently conducted in the world, testing, for example, the use of bispecific or new antibodies in first line, are completely agnostic and are not related to the molecular subtype. And in this slide, just to show you that, for example, in the last ASH meeting, there is a session dedicated to R-CHOP plus new drugs. And in this dedicated session, you can see that this lymphoma were not selected according to their molecular classification. And again, this trial were completely agnostic according to this classification. Maybe, however, this we can discuss this very important publication because it was the first real clinical trial demonstrating the benefits of the addition of new drugs to the R-CHOP backbone. And as you know, the guidance 1.0 adaptive strategy was published by Zhang 2 years ago. And in this trial, patients were receive experimental drug according to their molecular profile. 5 molecular profiles were defined: MCD-like, BN2-like, N1-like, SZB, TP53 mutated, and finally NOS subtype. And according to this molecular definition, patients receive drugs that were adapted to this molecular feature. And for example, ibrutinib were given in MCD subtype. Lenalidomide were given in N1 or NOS subtype. Tussidostat were provided for SZB patient, and decitabine was given in patient with the TP53 mutated subtype. And in this quite limited number of patients, the clinical trial was positive, showing benefit of targeted drug in overall survival and PFS in this trial. And they use a very simple gene expression profile and gene panel to define this molecular subtype, leading to a new project that is called Guidance 2. Again, it's a study comparing the efficacy and safety of genotype guide R-CHOP X versus R-CHOP in patients with diffuse large B-cell lymphoma. And the patient will receive R-CHOP 6 cycles in the standard arm, or R-CHOP plus experimental plus drug if there is a target in the subgroup. And in this trial that plan to enroll more than 1,000 patients, the end is planned in 2026. 3 drugs will be tested: orelabrutinib, lenalidomide, and decitabine. So to conclude, how to move beyond molecular stratification in the near future. Maybe we have 3 or 4 or 5 new strategies: targeting key master gene, define new molecular tools for strategy, to decide to treat patients according to predominant molecular subtype, to propose new molecular approaches, or to, donc, for example, is it possible to target very key master gene in large B-cell lymphoma? It was proposed by this recent publication by Moran's team, based on the analysis of a large cohort of exome data. And in this paper, they tried to find some key master genes that are shared by both large B-cell lymphoma, follicular lymphoma, or Burkitt lymphoma, and try to define a list of high confidence genes that are really driver for B-cell lymphoma. And by this way, they find a short list of less than 10 genes, and I show you in this slide the more important gene that maybe we can target in large B-cell lymphoma. But you can see in this list that, for example, we do not have really drugs that can target this gene. Maybe BCL6 with the use of degraders is an interesting target. But for example, we do not have drugs that are able to target, for example, FOXO1 or cyclin C3. It's another way to show you this data. Maybe we can use new tools that are more flexible than the molecular classification. For example, we can use ctDNA and decrease of ctDNA after R-CHOP. It was proposed in these clinical trials. Maybe we are involved in this clinical trial based on the ctDNA decrease after one cycle of R-CHOP. In case of insufficient decrease, we propose to add to R-CHOP glofitamab, and in case of rapid decrease, fast decrease of ctDNA, you treat by the standard arm of R-CHOP. And more than 60 patients were enrolled in this clinical trial that will be discussed last year in the ASH meeting, but also I think this year in the upcoming ASH meeting. You can also keep this same strategy based on ctDNA decrease, whatever the molecular subtype, and choose to treat your patient in case of MRD positive by CAR T-cell. It's proposed in this ALPHA3 trial using CAR T, allogenic CAR T. You can also combine both molecular classification or molecular feature and ctDNA or PET scan imaging after immunochemotherapy. And this was proposed by our Switzerland colleague and presented in the last ICML meeting. In this trial, patients with MYD88 mutation will be treated by R-CHOP plus acalabrutinib. It's arm A. And in the absence of this mutation, patient will be tailored by both PET scan analysis after 2 cycles of chemotherapy and also ctDNA, defining patient with high risk, ctDNA positive and PET scan positive, and patient with lower risk based on the negativity of these 2 markers. This trial is ongoing. We do not have conclusion for the moment, of course. We can also now maybe detect patient according to new molecular tool. For example, in our center, we use shallow sequencing to detect patients with high risk, molecular high risk. Shallow sequencing is quite easy to perform, it's not expensive. You can use ctDNA to detect this copy number abnormality, and you can define high risk, high molecular high risk. There is one publication demonstrating that this techniques is predictive of the outcome in patients treated by CAR T cell, for example. Another way to classify your patient is to use new classification that are coming or or presented very soon. For example, my colleague from Pierre Millepied, Sandrine Rouland, and Bertrand Nadel's team define new molecular classification based on 5 archetypes, and this archetype were defined by single-cell RNA-seq on B cells. Of course, the translation of this new molecular archetype for the clinical practice is an open question. You can also perform new classification based on RNA-seq and single RNA-seq or with the microenvironment. In this publication, recent publication, Lee and colleagues define 3 molecular subtypes based on the microenvironment. For example, microenvironment enriched in endothelial cells, microenvironments based on stroma cells and LCT cells, and finally a text subtype based on the enrichment of exhausted T cells and superactivated macrophage. So it is likely that this new molecular classification will impact our decision making in large B-cell lymphoma. Of course, the goal is to combine both molecular classification of B cells and molecular classification of the microenvironment in one single classification. And it's maybe the challenge of the following year. So to conclude my talk, HCHOP plus a new drug versus HCHOP remains, for my opinion, an important driver of clinical research in large B-cell lymphoma. And to date, with more than 15 trials underway worldwide, but with a limited number of trials driven by molecular feature. There is some trials that are positive according to the ABC MCD subtype, and maybe Polarix is the best position to become a new standard in this subtype ABC or C5 or MCD. The relevance of current molecular large B-cell lymphoma classification is unknown in the area of new first-line immunotherapy strategy involving bispecific or CAR T-cell, for example. However, the role of lymphoma microenvironment is most likely crucial. We have new tools for adapting pair therapy that seems more promising for daily practice, in my opinion, and flexible than the molecular subclassification. And I'm pretty sure that we will include now in our decision making cfDNA or interim PET for our patient. There are new molecular archetypes that are coming soon, and we expect that this new classification will benefit for our patient. It means that there will be many opportunities for academic research in this setting. So thank you, and I am open for your question now.
Thank you, Dr. Jardin. Wonderful lecture. I think this is the future in the next 5 years. The entire paradigm will be changed in the treatment of diffuse large B-cell lymphoma based on your talk, because the molecular classification, I think, will be the winner game in the near future. And with that, I request all our discussants to please put the hand raise signs so that we can start our questions session with Dr. Jardin. Before the questions keep on pouring, sir, I have set some few questions for you. My first question is: you showed so many models of the molecular classification. Which model would you like the most? And very important model, because that gene panel, 5, 6 gene panel, what you showed, is that all sufficient because to start a new therapy in diffuse large B-cell lymphoma? So which is the best molecular panel which you like to suggest, sir, for all of us?
Sorry, can you? It's
So
difficult to hear you.
are you
I
able to
think
hear me, sir?
it's very low. Maybe you can.
Yeah. Uh, is it okay? Are you able to hear me?
It's better. It's better.
Better. Okay. So you showed so many models regarding the classifications.
Yes.
According to you, which model is the best model
Ah.
with minimum molecular mutation profile, so that in resource poor settings like India, we can practice the best medicine with the
Okay. Okay.
best molecular panel, five,
Okay.
6 best targets, which is must for the classification and best for the practice, because that is the game changer.
Exactly. So it's very difficult to tell you if there is a classification better than another one. The DLB class had the advantage to classify all your patients C1 to C5. By contrast, LymphGene, as you can see, classify only 50% of your patient, and it's not very uh, uh, um, you cannot use this classification in daily practice because you need whole exome sequencing, you need RNA-seq data. It's also true for DLB case. So I think the very practical English classification, UK classification proposed by the HMRN group, based on the analysis of a panel of 300 genes, seems very efficient to identify, for example, MCD. I think it's very, maybe the MCD or the AZB subgroup are the two very important subgroup to define, because at least for MCD, I think, for example, you can the polatuzumab can be more efficient in this subgroup, and in a daily practice, if you have only one subgroup to identify, for my opinion, MCD is very important. Uh, but for your daily practice, for example, in my center, we use a panel of 40 or 50 genes, as I show you, to define our molecular subgroup. And we don't use in for all patients, but for some patients with a clinical outcome unfavorable. And we also use fish analysis to detect the dark zone subgroup. I think that it's a new molecular definition of high risk patient based on dark zone gene expression signature. We don't use gene expression signature, dark zone gene in daily practice. It's not so easy. We have 2 days ago a conference with David Scott. David Scott, and he works a lot to define this dark zone signature. And he uses nanostring technology to define the subtype. But nanostring is not widely used in the world. The correlationship between nanostring and dark zone signature and immunohistochemistry is ongoing, and maybe we will have immunohistochemistry algorithm to identify the dark zone subtype. I think it's also a real challenge for the following years.
Thank you, sir. You shared very wonderfully regarding the which group Pola will be acting the most. Any subgroup, because you already showed about BTK inhibitors working very well with your MYD88 and CD79B subgroup. So, if your patient has got ABC subtype, and if your molecular analysis shows it's MYD88 or CD79B mutation positive, so when would you introduce the BTK inhibitor? Or is it wise to introduce the BTK inhibitor in any subgroup of the patients because on the based of the molecular profile what you have shown?
Again, it's very difficult to hear you. I have problem with my headphone. Can you repeat just your question?
Regarding BTK inhibitors,
Yes.
when to add BTK inhibitors with R-CHOP,
Yeah.
does your molecular profile will tell you that yes, this is the time you must add BTK inhibitors along with R-CHOP,
Yeah.
ibrutinib or acalabrutinib along with R-CHOP? For
Yeah.
example, if your molecular profile shows it's MYD88 or CD79B mutation positive
Mm.
and it is an ABC subtype, are you justifiable adding ibrutinib with R-CHOP?
Ah. It's yeah. You mean outside the clinical trials?
Yes.
We don't. Yeah. We for we use in fact we use ibrutinib, for example, in patient with CNS lymphoma. Uh, and it's true that in case in the setting of relapse, we use ibrutinib in patient with MYD88 mutation in my center outside clinical trials. In first line, in the daily practice, we don't add ibrutinib or acalabrutinib for this patient. The Phoenix trial, of course, was maybe we can expect escalade results that maybe we give positive signal for the addition of acalabrutinib in this trial. There is also the SAC trial. I'll show you. Yes, I think it's maybe these drugs will be very interesting in this setting. Yeah.
Thank you, sir. Another question everybody asking is, what is the timeline to get the molecular panel? Because we'll be starting with the
Ah,
treatment and the molecular panel will come afterwards. So it will be
yeah,
really
yeah,
helpful
yeah.
because what is the timeline? Yes.
That's a crucial point. Um, I think if you get the information after one or two cycle of fair chop, it's possible to change your strategy. So if you got the molecular panel, results of your molecular panels uh, just before or 2 weeks after your cycle two, AirChop cycle two, I think it's quite manageable to change because, for example, this is at this time, if it's possible, to get also PET scan analysis. So in a real ideal world, we can imagine that you have, after two cycles of AirChop, PET scan, ctDNA, and the molecular profile, for example. If you have this information, I think it's a very favorable situation to choose the best strategy for your patient. For example, move to CAR T cell, move to additive drugs, and you can see that there is many trials based on this marker. It's not the combination of three markers. Usually, it's only ctDNA or PET scan, but the combination of molecular feature, ctDNA and PET scan, it's only, for my knowledge, it's only proposed in the SAC trial that was presented in the ICML meeting.
Thank you, sir. Another question has come from Dr. Kannan. What is the clinical as well as therapeutic relevance of classification according to the molecular profile? I think mutation you already said. Another question is about from Dr. Akanksha. In your clinical practice, are you incorporating polatuzumab in limited stage DLBCL or with primary breast DLBCL?
The question is about polatuzumab in our daily practice. Unfortunately, in France, maybe Professor Tilly told you, we do not have reimbursement of the polatuzumab in first line.
Oh,
Yeah. So we cannot use polatuzumab, RCHP, RCHP in France, even if Professor T was the main investigator of the Polarix trial, and he published in New England. But in France, we are not allowed to use polatuzumab in first line. But if we do have the drug, I think we will select our patient with ABC subtype and stage 3 or stage 4, stage 3 or stage 4. Yeah.
not for limited stage DLBCL?
If
Can
if
use for
the
limited
if
stage 1
we have
stage?
if we have ABC subtype, I'm sure that we will use it. Yeah.
And about primary breast DLBCL?
Primary
Breast
breast.
diffuse DLBCL. Yes, breast.
Okay. It's not very frequent situation, but well, yeah, yes, we will use it. Yeah.
Okay. Thank you, sir. So I think there are no more questions left in the chat box. Any discussants want to ask any other question? Well, so sir, there are no more raising signs and no more questions from the chat box.
Okay.
Thank you so much for the fantastic
So
update.
it was a great pleasure to
It was
to
a
meet
good
you
learning
and
from
to
you, sir.
discuss with you.
Thank you so much, sir. It was a wonderful
Okay.
learning, great learning. Thank you so much.
Okay.
And I
Bye
thank all
bye.
the discussants present over here to participate in this webinar and meet you next Saturday, Sunday with another beautiful webinars. Thank you so much, sir. Thank you.
Okay. Bye bye.
Bye.
Thank you, sir.